Thank you very much, Omar, for that kind introduction. And I just want to get the first slide up. Okay, so thank you very much. And it's a real honor and a privilege to be speaking to all of you this evening, or it's morning here, but it's a rainy morning. So I'm glad you can make the time. I intend to cover a fairly broad range of topics in menopause, but obviously we can't touch everything. And I am happy to answer any questions that you may have towards the end. Okay, so this is what I want to talk about over the next little while. I want to talk in some detail about the physiology associated with the menopausal transition. And then I think importantly, I want to draw some of the differences between natural menopause and surgical menopause, which is an issue that I think has great implications for our patients. And then finally, of course, I have to talk about the risks and benefits of hormone therapy in postmenopausal women, because this is an area of some controversy. And I'm going to draw on international guidelines to show you that there is universal agreement for at least some of these. Okay, so let's get going with the physiology, which I think is important to understand as you formulate management plans for individual menopausal women. And the physiology of menopause, I'm going to talk about from different perspectives. Initially, as you know, menopause is a result of the ovarian reserve of functional follicles disappearing. This is from a fairly recent article which demonstrated that the follicular complement of the ovary reaches a peak at about the 5th month of intrauterine life. You can see it up here, so that by the time a female infant is born, they're already on the downslope, and there is a progressive decline in the number of, these are non-growing follicles, there's a progressive decline until absolute depletion, usually in the early 50s for most women. The straw staging system was a workshop conducted in North America designed to look at the different phases of reproductive aging, that is the transition from the reproductive years to the post-reproductive or post-menopausal years, and shedding some light on the menopausal transition. And to show how complex this is, initially the straw staging system had 7 stages, was subsequently increased to 10 stages. And so you can see there is a science about this transition that has been followed in the literature. Ovarian aging across the menopausal transition is something that varies from one woman to another. Generally speaking, through their reproductive life, women have stable and predictable ovarian function, but each woman reaches a critical level of follicle depletion, subsequent to which her life experiences, symptoms, and morbidity will change and will vary from the next woman. And some of the factors that modify the rate at which this change occurs and the nature of the changes that occur, some of these are ethnic, some of these obviously are genetic. And in fact, when a woman presents to us with early menopause, our first question is often, and when did your mother go through menopause? Because this is a clearly transmissible factor. Any woman who has a condition that affects the health of the ovaries and may warrant surgery, such as endometriosis, will have this intervention, the disease and the intervention, affect the speed at which she loses ovarian reserve. In terms of the symptoms and the speed at which changes happen, there are, of course, changes that occur due to a woman's age and physical changes that occur primarily because of menopausal change. And we're going to come to those, which will be different for individual women. Then there are phenotypic and lifestyle factors. As I'll show you, there is a difference between obese women and thin women in the experience they have of the menopausal transition. And depending on where a woman lives and the health system in which she lives, there will be variable use of hormone therapy to mitigate a lot of these symptoms, so that, again, an individual woman's experience may differ from others because of use or non-use of hormone therapy. And then there are societal perceptions of menopause, because in some societies, the menopausal transition is seen as a retrogressive step. In other societies, often in primitive societies, it's seen as a maturation for women. So societal perceptions also an important part of this. So I'm going to focus first on endocrine changes, which I think will form an appropriate background for the response we have for managing symptoms and morbidity. As you know, anti-Müllerian hormone is produced by the actual antral follicles a woman has in her ovaries, and there is a progressive decline as a woman nears the actual age of menopause, and this is progressive throughout the reproductive years. The solid line in this curve is the mean AMH level, and below is the median level, showing that as a woman approaches 50, generally speaking, her AMH level will approach 0. And the AMH level has been touted as a means of predicting when a woman will become menopausal, but unfortunately, there hasn't been a reliable study showing that there is a formula you can use incorporating AMH levels to predict the actual age of menopause. So this is an observation, but unfortunately not a good predictor of menopause. The Study of Women Across the Nation, or SWAN, is an American enterprise which has looked at multiple aspects of women and women's aging. And this is a graph from one of their studies looking at changes in serum estradiol as a woman transits the menopausal phases. And curiously, it is demonstrated that the majority of women, these two curves, have a slow or flat decline in estradiol levels, and less than a third of women have what we see as the classical decline in estradiol changes, that is a rise and then a very steep decline, precipitating estrogen withdrawal symptoms. In fact, the majority of women, or at least more than 50% of women, will have a steadier decline in estradiol levels, which is to their advantage. And androgen levels have been studied in multiple cohorts, and these show that, the studies show that adrenal androgens, typified by DHEAS, will decline progressively through the reproductive years, as will androstenedione levels and testosterone levels, so that the bulk of reduction in androgen activity is actually during the reproductive years, and following menopause, there is actually less of a decline than one would expect. I'm going to come back to this when we talk about surgical menopause, but I think you can observe that there is a steady decline through a woman's lifespan in production of both adrenal and ovarian source androgens. Neurological changes are an important part of the menopausal transition. And I just want to stop for a minute and talk about how neuronal function relies on production of ATP through the Krebs cycle, relying on glucose as the key fuel for neuronal activity. And glucose is transported into the brain or mediated by these transport mechanisms which are moderated by the action of estrogen. So estrogen deficiency will mean that there is less transport of glucose into the brain and less immediate production of ATP for neuronal activity. If there is a reduction in glucose provision in diet or a reduction in estrogen activity, the brain begins to rely on ketone bodies produced primarily from the liver as a source of energy. But if a woman is unable to produce a steady supply of ketone bodies in the face of either glucose deficiency or estrogen deficiency, then she will begin to rely on oxidation of fatty acids in glial cells to produce ketone bodies, in fact, allowing the brain to start auto-digesting. So it's important to recognize that an estrogen deficiency situation, such as the menopause, will have an effect on glucose transport into the brain and subsequent production of the ATP required for neuronal function. And we do know that there are changes in neurological function that aren't reliant necessarily on glucose transport, but these are more genomic changes, changes in cognitive function that will affect these parts of the brain, particularly the hippocampus. The mood change, chiefly depression, is a result of estrogen deficiency in the midbrain, and sleep disturbance, again, primarily affecting the hypothalamus. And vasomotor symptoms, we're now learning, primarily being a result of neurotransmitter changes within the hypothalamus and not so much the thalamus. So menopause is associated with measurable changes in different parts of the brain, which result in these changes in cognitive function, sleep activity, and mood change. From one of the cohorts I'm going to talk about with regard to surgical menopause has shown that estrogen, by and large, is neuroprotective. And this is a clinical demonstration that women who undergo surgical menopause, that is removal of the ovaries before age 45, they have an increased risk of neurological or mental disease later in life, unless they are given estrogen replacement. And we do know that women who have a stroke, for example, who are on estrogen-based therapy will recover much faster from the effects of the stroke than women who are not on estrogen therapy. And this appears to arise from both genomic and non-genomic effects, which tend to preserve neuronal viability, antioxidant effects, and as I've shown you, the ability to transport glucose into the brain to allow normal neuronal activity. So from multiple aspects, estradiol, or estrogen in general, is neuroprotective. And I think that's an important consideration in looking at the management of older women and neuronal dysfunction. We do know that women who are monitored over the menopausal transition will show a progressive decline in verbal memory, both immediate and delayed, although there is some recovery in delayed verbal memory in the late post-menopause. But generally speaking, verbal memory does decline. And depressive symptoms, which I think we tend to associate with the menopausal transition, in fact, don't seem to increase in the post-menopause, but they are shown to be present in significantly higher proportions in women who are perimenopausal. So women who are perimenopausal appear to be developing depressive symptoms, which subsequently are not mitigated by transitioning into the postmenopause. This is, mind you, this is depressive symptoms. I should note too that there is a specific form of depression which appears to develop in perimenopausal women and appears to be relieved specifically with transdermal estradiol. So again, we'll come back to depressive symptoms and mood change. The key thing that affects quality of life in menopausal women is the disturbance of sleep. And this involves multiple aspects of sleep, including trouble falling asleep and waking up early. But the predominant sleep disturbance is waking several times during the night. And as I'll come back to, we see that in women who have had the ovaries removed, sleep disturbance is actually heightened in all these forms. So sleep disturbance is a significant part of menopausal transition. But the key neurological change in postmenopausal women, or the hallmark, is the hot flash, which again, women may have difficulty recognizing early on, but as it increasingly affects quality of life, will recognize as a significant disturbance. It's interesting to note that it was 40 years ago that Bob Casper, a friend of both Mohamed and myself, when he was a fellow, published this paper showing that with frequent sampling of LH levels, every time a woman had a hot flash, she was found to have a surge of LH in serum, which led to the obvious conclusion, perhaps it's LH that's causing the hot flashes, but that obviously proved not to be the case, as multiple investigators subsequently found. And this association took another 30 years before it was effectively elucidated. And the connection between LH levels and hot flashes was found to be mediated by the Kindi neuron, specifically neurokinin B. And this is just an example that in the medial basal hypothalamus, monkeys that had undergone bilateral oophorectomy had a significant increase in neurokinin B activity in this part of the hypothalamus. And the story is slowly coming together. I'm just going to go back, actually, that's not showing up as expected. But what's now understood is that with estrogen deficiency, this increase in the activity of neurokinin B modulates not only GnRH release, but it also modulates signals that come from heat sensors in the skin. So the increase in neurokinin B that results from estrogen, lack of estrogen feedback, amplifies the release of GnRH from the medial basal hypothalamus and causes LH release. But at the same time, it's amplifying the signals from heat sensors in the skin that lead to a heat loss mechanism that is vasodilatation. So neurokinin B activity is doing these two things. It's amplifying both GnRH release and it's amplifying the effect of these heat sensors in the skin, resulting in vasodilatation. Now, this has been confirmed, if you like, indirectly, with a study reported 5 years ago in which premenopausal women, in this case 10 premenopausal women, were infused with either a placebo or neurokinin B. And the subjects infused with neurokinin B had, in 8 out of 10 cases, developed subjective hot flashes. So we did have evidence from a clinical intervention that neurokinin B activity in the medial basal hypothalamus appears to be the trigger for the development of hot flashes. And the next step, of course, was to develop blockers, antagonists for the receptor for neurokinin B called neurokinin 3. And these antagonists are able to impede and effectively wipe out hot flashes in postmenopausal women within a few days. So there is increasing evidence that neurokinin 3 receptor antagonists will be the way of the future in controlling hot flashes in symptomatic women without estrogen effect. And these agents are all in phase 3 trials in Europe and in North America. And we anxiously await their arrival for use in postmenopausal women who choose not to use hormone therapy. Changing again, bone and joint changes. We do know that bone density is a result of trophic effects from osteoblasts and remodeling or resorption effects from osteoclasts. And the maturation of osteoclasts is mediated by this binding of a rank ligand to the rank receptor on immature osteoclasts. This binding is impeded indirectly by estrogen, because estrogen stimulates production of a rank ligand agonist called osteoprotegerin. And osteoprotegerin effectively eliminates this binding of the rank ligand to its receptor and subsequent maturation of osteoclasts. So in estrogen deficiency states, this binding occurs unimpeded and the maturation of osteoclasts accelerates so that the activity of osteoclasts in resorbing bone and reducing bone density outstrips the trophic effects of osteoblasts. And that is why bone loss after menopause accelerates. This is a basic science study showing that as estrogen levels fall and FSH levels rise, there's an increase in this telopeptide, which is a marker for bone resorption. And subsequently, subsequently, bone loss is accelerated post-menopause, particularly in trabecular bone, as in the vertebral column, and less readily in cortical bone in the forearm and hip. And that leads to an increase in the incidence of initially vertebral fracture after menopause, followed by wrist fracture and hip fracture. And you can imagine if a surgical menopause is carried out, then menopause is not occurring at age 50, but is occurring earlier, all of these curves being shifted to the left, and the incidence of hip fracture, which normally starts to rise when a woman is in her 70s, will start to appear when she's in her 50s and 60s, something to be avoided because of the associated mortality. Estrogen has beneficial effects in articular tissue and joints, and it has an effect in cartilage, for example, to reduce the activity of cytokines, so acting like a non-steroidal anti-inflammatory drug in cartilage. It regulates remodeling of subchondral bone. It decreases the reduction in muscle cell activity and production, increases the synovial secretion within joints, and strengthens ligaments. And so when a woman is estrogen deficient, she is far more likely to develop arthritis, osteoarthritis, than a man is. And DIP is distal interphalangeal osteoarthritis, the osteoarthritis that women will have in their fingers, becoming a significant feature in most women shortly after menopause, and less of a feature in men. The same with osteoarthritis affecting the knee and hip, becoming a much more significant issue as a woman passes through menopause. Urogenital changes, again, a major part of menopausal physiology. The blue in this diagram shows the areas that have estrogen receptors. And I think I need to emphasize that, contrary to what is expected, the urethral mucosa and the mucosa covering the trigone of the bladder is also estrogen sensitive, so that in estrogen deficiency states, there is a loss of estrogen activity throughout the genital tract, but also in the lower urinary tract with subsequent effects. I just want to show you here, this was a postcard study of almost 1,300 women aged 61 in Sweden, asking them about vaginal symptoms and urinary symptoms. And this showed that women who had reached 60 had a significant number of vaginal symptoms, and a third of them had avoided intercourse because of the amount of vaginal discomfort associated with loss of estrogen activity. In the urinary tract, it's important to note that estrogen deficiency results in a thinning of the urethral mucosa, which is an important part for a woman to maintain continence. There's also a thinning of the mucosa covering the bladder trigone, and these exposed sensory nerves will lead to repeated stimuli to void, that is, leading to urgency and frequency. But the lack of tone in the supporting muscles and ligaments and the loss of urethral mucosal thickness means that a woman's natural barriers to incontinence are greatly weakened, and incontinence becomes a part of postmenopausal women's lives. And in this same study of 61-year-old women in Sweden, almost 3/4 of them reported some degree of urinary incontinence, half of them some degree of stress incontinence, and 2/3 of them had changed their voiding habits, going to empty their bladder more frequently because of these changes. So that these are changes in voiding habits and urinary health that can be, to some extent, mitigated by estrogen-based therapy. And importantly, we need to understand what happens in the cardiovascular system as a result of estrogen deficiency. Estrogen has both rapid non-genomic effects and longer-term, or that is, genomic effects. The rapid effects are often underappreciated, that estrogen is, in healthy vessels, a potent vasodilator working through the effect of nitric oxide, which itself is a vasodilator. And in terms of coronary disease and stroke risk, the genomic effects of estrogen in reducing atherosclerosis and causing a change in endothelial cell growth, these are changes that will have an effect on the incidence of coronary artery disease specifically. We do know that the vasodilator effects in arterial walls are an important part of the menopause transition. Estrogen binding to both alpha and beta receptors in the endothelium of arterial walls, leading directly to an increase in nitric oxide synthase increased nitric oxide activity and directly leading to arterial dilatation. And this ability to promote vasodilation in arterial walls is something that declines significantly across the menopausal transition. The ability of arterial walls to relax and dilate becomes increasingly a non-event as a woman passes through the menopausal transition. The longer-term effects in lipids are also important. As a woman ages past the menopause, there is an increase in LDL, bad cholesterol, and a progressive decline post-menopause in HDL cholesterol with consequent effects on the risk of atherosclerosis. Apolipoprotein A shows a steady increase and not materially infected by menopause, but apolipoprotein B, B being for bad, increases significantly in association with the menopausal transition. So these are adverse changes in lipids that progressively will increase the risk of atherosclerosis. And this has been demonstrated in women who are high in estradiol, either therapeutically or endogenously, will have much less progression. In fact, will tend to have a reversal of the trend towards reduced arterial diameter, whereas women who have low estradiol levels will tend to have increased atherosclerosis, increased vascular narrowing. Okay, so the endocrine effects, to summarize, estradiol levels decline over the menopausal transition with, according to the SWAN data, 4 distinct trajectories, but at least half of women having a slow decline in estradiol levels. FSH levels rise, as we know, inhibin B levels decline because they are a product of follicular activity, the same with anti-Müllerian hormone. Testosterone levels, not much change, and DHEAS levels, a marker of adrenal activity, rise during the perimenopause, peak during the early postmenopause, and then return to baseline, perhaps reflecting increased adrenal activity over the menopausal transition. In terms of neurological effects, we know that cognitive function declines, with declines in both cognitive speed and verbal memory. As I demonstrated, there is a reduction in neuronal introduction of glucose, and estrogenic neuroprotection will decline. A mood change tends to occur in the perimenopause, but not so much being transmitted into postmenopause. And the key effects on quality of life will be the occurrence of hot flashes and sleep disturbance. The bone effects mean that there is increased bone resorption and an acceleration in fracture rates. The inflammation, impaired subchondral bone remodeling leads to increased rates of osteoarthritis, and the urogenital effects resulting in vaginal irritation, dyspareunia, urinary symptoms, and altered voiding habits. And in terms of cardiovascular effect, the reduction in estrogen activity leads to a reduction in vascular endothelial-dependent vasodilatation, which is a short-term or immediate reaction to stress. The menopause-associated changes in lipids lead to a long-term increase in atherosclerosis. So all of these effects can be, to a large extent, mitigated by estrogen-based therapy, although, as I noted, in the next couple of years, we hope that the neurokinin 3 antagonists will give us an option for treating vasomotor symptoms without using hormone therapy in women in whom that's contraindicated or not preferred. So that's the endocrinology or the physiology of the menopausal transition. So now I want to spend a few minutes talking about the difference between natural and surgical menopause. And we've emphasized in the physiology what happens with natural menopause. Surgical menopause is the abrupt introduction of a hypogonadal state through either surgical or other therapeutic interventions that remove ovarian follicular activity. The straw staging system emphasized the menopausal transition, which in passing from the reproductive to the post-reproductive years can take up to 5 years, and it's important to emphasize, allows for a period of adjustment in individual women to the hypogonadal state. In women who undergo a surgical menopause, it's important to emphasize that there is no perimenopause, so no period of adjustment, and women are precipitated into a hypogonadal state. I just want you to focus for a minute on the lower line here. This is looking at production rates of steroids in women who are in the reproductive age, in the postmenopause, and women who undergo a surgical menopause. And perhaps not surprisingly, women who have their ovaries removed, by and large, have similar, if not the same, estrogen levels as women who go through a natural menopause, because these women have no ovarian follicular activity to produce estrogen. In this case, the potential for that has been removed, but essentially the estrogen levels are the same. The important thing to emphasize is that these women have had a transition phase to go from reproductive age levels of estrogen to post-reproductive age. And these women have had an abrupt decline in estrogen activity. Adrenal activity doesn't appear to change dramatically in women who have their ovaries removed, but it is important to note that androgen levels, particularly testosterone and androstenedione to a lesser extent, are dramatically lower in women who have had their ovaries removed. In circulating testosterone, roughly 25% of it comes directly from ovarian secretion, 25% from the adrenal, and roughly 50% from peripheral conversion of other androgens. Androstenedione, roughly 50% of it will come directly from ovarian secretion. So removal of that source does mean that androstenedione levels are precipitately lower, and when that's converted to testosterone, again, that source is significantly reduced. So the key difference between women who have a surgical menopause and women who have a natural menopause is the difference in circulating androgen levels, but also the abrupt transition from a normal estrogen activity to hypogonadism. And not surprisingly, that leads to, when we compare women who go through a natural menopause with bilateral oophorectomy, we see a significant increase in any hot flashes. Actually, this is not statistically significant, but the proportion of women who have moderate or severe hot flashes, bilateral oophorectomy, according to this Italian study, is statistically significant. And the women who have daily hot flashes tends to be higher as well. The bottom line is that the frequency and severity of hot flashes appears to be greater in women who have a surgical menopause. I mentioned this before, the pattern of sleep disturbance. Again, women who have had their ovaries removed will have a significantly greater proportion of sleep disturbance than women who go through a natural menopause. And this is looking at quality of life from a Canadian study that used the menopause quality of life, or MenQual, scoring system to assess quality of life from a number of perspectives in women pre and post oophorectomy. And this showed that, as expected, the women who had bilateral oophorectomy had a significant increase in their MenQual scores in the vasomotor domain, an increase in score meaning a greater degree of disruption of quality of life. And the other significant change was in sexual function and sexual satisfaction. And again, there's another study from Australia, which has actually only been published this month, confirming this again, that women who undergo bilateral oophorectomy have a fairly profound reduction in sexual satisfaction post-surgery. Now, I'm going to talk for a minute about the consequences of bilateral oophorectomy in terms of morbidity. And there are three key databases that we use to confirm the association between surgical menopause and long-term morbidity. And these are the Nurses' Health Study, which was US-based, but subsequently expanded to include Canadian women, the Mayo Clinic cohort, and the English Hospital episode statistics. And they're all quite different in their approach to assessing morbidity. The Nurses' Health Study, you may be familiar with, was launched in 1976 and updated in 2010. Started out with over 120,000 120,000 nurses, most of whom were female, agreeing to regular assessment of health via contact indirectly. So these were not women who were assessed objectively, but instead reported their state of health annually. And this has been very helpful in assessing the effects of aging and menopause on women's morbidity and mortality. The Mayo Clinic cohort was a much smaller retrospective study, essentially of about 2,400 women who underwent removal of either one ovary or both ovaries. Again, this was updated more recently, but this was a much more intense and focused cohort who were objectively studied for various kinds of morbidity and mortality. And the English Hospital episode statistics study used national databases to assess the associations between hysterectomy with or without oophorectomy and subsequent morbidity and mortality. And I just want to talk about each of these in turn to show how they have given us insights into the effects of surgical menopause. This is, I'm sorry, I'm just going to highlight these things from the Nurses' Health Study. And this was an update in 2013 that showed that all-cause deaths in women who had bilateral oophorectomy was increased. In fact, I'm only going to highlight the ones that were statistically significant. In this case, lung cancer, interestingly, was an increased risk in women who underwent bilateral oophorectomy. Colorectal cancer was increased, and so was total cancer, all forms of cancer. Interestingly, coronary artery disease, the 95% confidence intervals touched one, so this was of marginal significance, but overall cardiovascular disease, combining coronary disease and stroke, was also significantly increased in women who had bilateral oophorectomy. So this is a substantial body of data, but it is observational. Remember, these nurses were reporting their own level of health, and we rely on their honesty and accuracy in drawing these conclusions. The Mayo Clinic cohort study had a recent assessment of 18 different potential morbidities and found that in comparison with referent women who were all age matched with intact ovaries, the women who underwent oophorectomy had an increase in each of these morbidities, in depression, in dyslipidemia, in cardiac arrhythmias, in coronary artery disease, arthritis, asthma, COPD, pulmonary disease, and osteoporosis. And interestingly, did not find that lung cancer was increased. The English HES data curiously showed that heart disease, any cancer, breast cancer, and ovarian cancer all favored ovarian conservation. And it may be difficult to understand why ovarian cancer was increased. Remember, this was a cohort of women, a substantial cohort of women who had a hysterectomy and who either had ovarian conservation or ovaries removed. Twice as many women having ovarian conservation as having ovaries removed. And of the women who had ovaries removed, 18 of them out of this cohort were actually found to have cancer in the tissue removed, whereas of those women who had ovarian conservation, only 7 subsequently developed ovarian cancer, which led to this conclusion that ovarian conservation favored this cancer. In addition, colon cancer, bladder cancer, and other forms of cancer, again, all favored ovarian conservation. So this is a substantial, again, national database confirming that there is a lot to be said in favor of ovarian conservation in these women undergoing hysterectomy. These women were undergoing the surgery over a 10-year period and were followed for a mean of more than 10 years. And the last observation is in cognitive decline, which again is something that is increasingly coming under scrutiny. And this is a study of just under 2,000 women from 2 longitudinal studies of cognitive decline. One of them, the study of Catholic nuns who had agreed to allow continued observation and subsequent autopsy, and another study in Chicago that looked longitudinally at cognitive decline. And this study showed that women who underwent bilateral oophorectomy, surgical menopause, before age 43 had a significant increase in cognitive decline, whereas women who underwent surgical menopause at age 43 or later had less of a significant decline, and in fact were not different from women who underwent the natural menopause. So for cognitive decline, 43 and under for the age at surgical menopause appeared to be the critical number. So these morbidities that were associated with surgical menopause were able to be largely mitigated with estrogen-based therapy until the average age of menopause. They didn't have to keep going up to the same age, up to their 50s and 60s, but until the average age of menopause. But as they each demonstrated, it might be better to avoid these morbidities by retaining the ovaries at surgery, so at hysterectomy, rather than routinely removing the ovaries, leaving them intact, or at least leaving one ovary intact. I'm going to talk about, this is just to remind me that we're going to move into risk, and who knew that swimming or surfing was such a dangerous activity. I'm going to talk now about the risks and benefits of hormone therapy that we use in the management of menopausal symptoms and morbidity. And a lot of this is controversial, which is why I have gone back to the guidelines, international and Canadian guidelines, to see what the professional conclusions are, conclusion of professional associations regarding the risks and benefits in the management of postmenopausal women. I'm going to start with indications for menopausal hormone therapy, and we have to rely on the US FDA for this because no other country appears to have a regulatory body that has specified what the indications for using hormones in postmenopausal women should be. And these are what the FDA, for better or worse, has approved as indications for menopausal hormone therapy. First, and obviously, vasomotor symptoms, because multiple double-blind studies have shown that up to 80%, and sometimes a bit higher, 80% of women will have relief of vasomotor symptoms using estrogen-based therapy. Secondly, prevention of bone loss. We do know from double-blind studies that hormone therapy will reduce bone loss, and the WHI, the Women's Health Initiative, showed a reduction in fractures in treated postmenopausal women. Thirdly, premature hypoestrogenism, which includes surgical menopause or women who have hypogonadism, premature ovarian insufficiency, women who have no contraindication to estrogen use will have improvement in symptoms, but will also have prevention of bone loss, prevention of changes in cognitive function and mood, and the observational studies have indicated a reduction in heart disease. And fourthly, genitourinary symptoms, and this of course means that estrogen therapy can be used locally if this is the only indication for treatment. So these are the guidelines that I've referenced in talking about risks and benefits. The SOGC guidelines are the oldest, but they are being updated and new ones will be published later this year. The Endocrine Society had a comprehensive guideline published in 2015. The International Menopause Society, again, a comprehensive set of guidelines in 2016. And the North American Menopause Society put out a substantial position statement or guideline in 2017. I've also briefly referenced the global consensus position on the use of testosterone in women, but I won't be referring specifically to that in the next few minutes. So the contraindications, the guidelines all agree that we should avoid using menopausal hormone therapy, specifically estrogen-based therapy, in women with unexplained vaginal bleeding, which makes sense, women with a history of stroke, TIA, transient ischemic attacks, myocardial infarction, pulmonary embolism, or venous thromboembolism. They also should be avoided in women with a history of breast or endometrial cancer and women with active liver disease. And I don't think these are controversial. I think we would all tend to avoid treatment in those women. But the guidelines also suggest that caution should be used in women with diabetes, and we're talking particularly about insulin-dependent diabetes because it may complicate management. Women with elevated serum triglycerides, because oral estrogen does increase serum triglyceride levels further and may precipitate pancreatitis. Women with active gallbladder disease, because all forms of estrogen increase cholesterol excretion in bile and reduce gallbladder activity, which together will increase the risk of developing gallstones. In women who have an increased risk of breast cancer for whatever reason, or cardiovascular disease, and women who have a history of migraine with aura because of concerns about precipitating stroke. The North American Menopause Society position statement also includes that women with dementia should not be considered for hormone therapy, women who have a personal history or inherited high risk of thromboembolic disease, particularly if they are using oral estrogen, women with porphyria, where there's concern that endometriosis might reactivate. Again, this is now a subjective concern, where there is concern that migraine headaches may worsen, or where there is concern that uterine fibroids may grow. There is obviously a need to be cautious. The benefits, though, it is important to recognize that we give hormone therapy to postmenopausal women not because of concern about morbidity, but because there are likely to be improvement in a number of symptoms and quality of life. And particularly, this includes vasomotor symptoms, because we still do not have anything that matches the ability of estrogen-based treatment to reduce hot flashes. The same with sleep disturbance, which may be a result of vasomotor symptoms, but may also be a direct result of estrogen deficiency. Women who have both vaginal symptoms from estrogen deficiency and women who have urinary tract symptoms, including various degrees of prolapse, and women who have disordered or hypoactive sexual function will have improvement with menopausal hormone therapy. And arthralgia, or what the SOGC guidelines quaintly call aches and pains. So these symptoms will all improve with the use of estrogen-based therapy. But there are also theoretical benefits. There are potential reductions in bone loss, which I think is likely to be unequivocal, and reduced risk of fracture. The Women's Health Initiative also showed a reduction in the onset of type 2 diabetes in women treated with estrogen-progestogen therapy. Colorectal cancer appears to be reduced in women who are treated with medroxyprogesterone acetate. It doesn't appear to be reduced in women who use other forms of progestogen. And endometrial cancer in women who are anovulatory or who have estrogen dominance and a tendency to endometrial proliferation and hyperplasia, the introduction of a progestogen will reduce the risk of transforming into endometrial cancer. And coronary heart disease, which again has an asterisk by it because it appears to be age-related. And the Women's Health Initiative studies initially suggested that all postmenopausal women would have an increase in coronary heart disease, but subsequent reanalysis, and it took 5 years for this to be disclosed, showed that the risk was entirely in women over age 70. And this is the basis for recommending that women should not begin menopausal hormone therapy if they are more than 10 years postmenopause or over age 60. That is, they should not begin. But if they have begun before that, then they can continue into their 60s and 70s. The risks of menopausal hormone therapy, again, abstracted from the guidelines, I think these are fairly unequivocal. And I think venous thromboembolism is so widely recognized that I'm not going to show more evidence about that. There is, we know, an association between use of oral contraceptives and venous thromboembolism. The same applies to oral estrogen, but it's questionable whether transdermal estradiol does have any risk on venous thromboembolism. And the same with stroke. And I'm going to spend more time talking about stroke and then endometrial cancer, gallbladder disease, and finally breast cancer. This is what the International Menopause Society says about stroke risk, and I think this is the clearest statement, that stroke incidence may be increased when hormone therapy is initiated in women over age 60, but it's not associated with hemorrhagic stroke, so just with ischemic stroke. Initiation of hormone therapy in women under age 60 or less than 10 years since menopause doesn't increase the effect of stroke, according to 13-year follow-up data. And the Endocrine Society is much more succinct. They just say may confer a small risk of stroke. The SOGC guidelines, again, doesn't say definitively what the risk is, but says risk factors should be assessed and addressed. And the North American Menopause Society position statement goes back to what the IMS said. A meta-analysis of RCTs found no increase in stroke in women aged younger than 60 or within 10 years of menopause onset, but they do note that observational studies are mixed. And the observational studies also suggest that if you use lower dose oral or lower dose transdermal estradiol therapy, there will be less of a risk on stroke. Endometrial cancer, we mentioned that as a potential benefit of introducing hormone therapy by introducing progestogens to women who may have pre-existing endometrial proliferation. The Endocrine Society notes that reports have come from Europe of women using micronized progesterone and dydrogesterone in association with estrogen having an increase in the incidence of endometrial cancer with long-term use. And it appears that there is a concern about using micronized progesterone in particular, because micronized progesterone is not a potent anti-proliferative effect in the endometrium. The synthetic forms of progesterone, such as medroxyprogesterone acetate, norethindrone acetate, are potent anti-proliferative agents and do appear to protect reliably against endometrial cancer. So anybody given micronized progesterone, either continuously or with cyclical use, who develops abnormal bleeding, there should be a heightened concern about the risk of endometrial hyperplasia and cancer. And gallbladder disease, we mentioned that because of estrogen's intrinsic effects in bile excretion and the activity of the gallbladder, it is associated with an increase in the risk of gallstones, inflammation, and the need for cholecystectomy in women with oral estrogen therapy. There has been a suggestion from observational studies that transdermal estradiol doesn't carry the same level of risk, but I think that may not be confirmed if an RCT is ever performed. So I want to spend the last few minutes talking about breast cancer, because this appears to be the key concern of many postmenopausal women considering hormone therapy. And that's understandable because women who are menopausal at the average age and contemplating hormone therapy have friends who have developed breast cancer, but they tend by and large not to have friends who have developed osteoporosis or coronary heart disease. So breast cancer appears to be the primary consideration in women who are contemplating using hormone therapy. And it gets more complicated. As pointed out in the North American Menopause Society position statement, the effect of hormone therapy on breast cancer risk is complex and conflicting. And the effect on breast cancer risk may depend on the type of hormone therapy, the dose, the duration of use, how it's given, prior exposure to hormone therapy, and individual characteristics, including a family history of breast cancer. The International Menopause Society notes that the risk of breast cancer in women over 50 years associated with hormone therapy is a complex issue. I know that's just what you wanted to hear, but I'm going to try and reassure you. This is what happened in Canada and probably happened globally, that the Women's Health Initiative combined therapy study released in July 2002 resulted in a lot of women immediately stopping hormone therapy and not returning to it. And as I say, this was in what happened in Canada, and I'm not sure what happened in other parts of the world. Certainly it was heightened in the United States. where the effect of this report was significant. And I think it's important to remember that this was in the pre-internet era, so that the release of this report was primarily by press release. And we had no way of confirming or further investigating what the findings in this study actually were. And the branch of the NIH in the US that was responsible for conducting the Women's Health Initiative released this terse statement in July 2002, saying they were stopping the trial of estrogen plus progestogen because of an increased breast cancer risk and lack of overall benefit. They actually included also an increased risk of coronary disease in their statement. Now, what we learned subsequently after that bombshell press statement was that there had been a small increase in the incidence of coronary disease, in the incidence of breast cancer. Again, this looks terrible when expressed this way, but if you note that the y-axis was number of cases per year in 10,000 women, and this was actually an increase 7 cases per 10,000 women, or 8 cases of breast cancer in 10,000 women, which is a fraction of a percentage point. And overall, there had been no increase in the risk of death in this study in the therapeutic group. So we found this out slowly after the press release. And it took 5 years, as I mentioned before, it took 5 years before further study of the coronary heart disease risk to identify that all of the risk was in women over age 70, a group who we now know would not routinely be started on estrogen-based therapy because of this very risk. So in women, further analysis, women who would normally be the ones taking menopausal hormone therapy in their 50s actually had a reduction in the risk of coronary heart disease, but that took years and years to become clear. I'm just going to talk about the breast cancer incidence, and this was something, again, that took years to elaborate and to find out whether the degree of association that was implied by the initial study report was actually genuine. This was a study published 4 years after the initial report that looked at the incidence of invasive breast cancer according to whether women treated with hormone therapy had previously used hormone therapy or had not. And they found some interesting differences in the curves. You can see on the left that women who were treated started to show an increase after 5 years. The annualized incidence of invasive breast cancer in the treated group was 0.4%. And in the untreated group, which started to lag behind after 5 years, was 0.36%. In the group of women who had used hormone therapy before, and we're not talking oral contraceptives, this is using menopausal hormone therapy, the curve of women was roughly the same or a little more, and the annualized incidence was 0.46%. But the women who were given placebo had previously used hormones and were randomized to use placebo. The annualized incidence rate of invasive breast cancer was 0.25%. And you look at all of these curves and say, one of these is not like the others. So was this in fact a more correct annualized incidence? And was this treated group and this treated group and this placebo-treated group showing an unusually higher annualized incidence of invasive breast cancer? Well, as it happened, this group of women overall contained about 18,000 women. There was a much larger group of about 50,000 women who were participating in the dietary adjustment study of multiple aspects of health, including breast cancer. And in these women, they were randomized to either have a low-fat diet or a regular diet, continuing with the regular diet. And this was the incidence of invasive breast cancer. In the women who continued with the same regular diet, the annualized incidence of invasive breast cancer was 0.45%. And the women who reduced their fat content in their diet, the annualized incidence of invasive breast cancer was slightly reduced. But these figures overall were roughly similar to what we saw in the previous group. I've really done that, I'm sorry. Okay, so it led to the perspective that perhaps in the group of women who had previously been treated with hormone therapy, that there was in fact a selecting effect, so that women who were randomized to placebo actually had already been screened for breast cancer. And by contrast, the women who were treated with estrogen progestogen therapy appeared to have an increased risk, whereas the level of increase in risk was quite questionable. So the IMS, in response to a number of statements about the association between breast cancer and menopausal hormone therapy, concluded quite reasonably that the degree of association, that is, how important hormone therapy is in causing breast cancer, remains controversial. So I'm just going to summarize, and I'm sorry you've been very patient listening to this, the risks and benefits of estrogen-based therapy, and then I'm happy to try to answer any questions about this. The risk of venous thromboembolism appears to be largely restricted to women who take oral estrogen, as in oral contraceptives. The same is the risk for stroke. And again, the studies from Assiut have suggested that this is restricted to women over age 60 and likely is amplified in women on oral estrogen, less of an issue in women on transdermal estrogen. The breast cancer risk remains controversial, but I think we would say that with more than 5 years of use, most studies have shown a small increase in risk, and it appears to be progestogen specific. In other words, observational studies in Europe have indicated that the risk of breast cancer appears to be mostly associated with synthetic progestogens and is much less with natural progesterone, such as micronized progesterone. The risk of ovarian cancer is something that has been pointed out only in one study from the Oxford group, Valerie Beryl's group, and it relied on 52 studies, but 75% of the data in that meta-analysis came from 2 large studies, neither of which took into account the protective effect against ovarian cancer of oral contraceptives. So ovarian cancer remains a putative risk, and I think we're waiting for confirmation that it is actually a real risk of hormone therapy. Endometrial cancer, remember we said, is potentially reduced in women who have a tendency to endometrial proliferation and who begin using a progestogen. But in women who use micronized progesterone or dihydrogesterone, less anti-proliferative progestogens, there may be a small increase in the risk of endometrial cancer. Gallbladder disease is a direct effect of estrogen and its effects on gallbladder activity and the content of bile, and is an increased risk. The benefits, remember we said that in younger women, there appears to be a reduction in coronary artery disease And that likely is the case, but again, in using synthetic progestogens, the risk of coronary artery disease is not going to be as reduced because a randomized study called the PEPI trial did show that micronized progesterone was heart-friendly, but medroxyprogesterone acetate was not. Type 2 diabetes, again, we showed from the Women's Health Initiative that the incidence is reduced. The incidence of reduced bone density and fracture is also reduced in women on estrogen-based therapy. And colon cancer is reduced in women who use medroxyprogesterone acetate, but does not appear to be reduced in women who use other forms of progestogen. But the main benefit of estrogen progestogen therapy clearly is quality of life. That women who have a significant disturbance of life by sleep disturbance and hot flashes, mood change, changes in cognitive function, and urogenital changes will see a significant improvement in their quality of life with estrogen-based therapy, and that is why we use it. And at the most recent North American Menopause Society position statement said that there is no longer an upper age limit for discontinuing hormone therapy if the benefits are seen to outweigh the risks. And so increasingly, we're seeing women continuing with hormone therapy into their 70s and even 80s if they perceive that there is a benefit. So that's the end of my presentation, and thank you very much for your attention, and I hope that I'll be able to answer any questions you may have. But once again, thank you very much for your attention.
Well, thank you very much, Tim. That was very, very informative. A lot of information and a lot of food for thought, and I'm sure it's very educational. We received a lot of questions, so I'm just going to hand it to Omar so he can start moderating the question part.
Professor Khan, thank you very much for this informative, very well organized lecture. But we have a bunch of questions we'd like to share with you, and most of them are clinical questions and actual case scenarios. I would like you to have time to answer them. If they can allow me to share my screen, I typed this question to the screen. Before starting question, just gentle reminder for the next week session, the 28th of March, by Professor Samasiano about the placental endocrinology, and Associate Professor Dr. Fatin Ahmed on the placental-mediated pregnancy complication. As regard to the questions, I had a lot. I typed them so we all can read and go with them. I will read them one by one, and I hope. Can you see my screen?
Yes, we can.
Yes. Thank you.
The first question is a 48 years old para-4 women, working lady, average BMI, non-diabetic, non-hypertensive, non-smoker, with no history of breast cancer. She is coming asking for keeping her quality of life and asking me to counsel her. It should start, or I wait symptoms, or I should have some hormonal assay before I should go for that.
No, I think that's a very pertinent question. Nominally, yes, hormone therapy is just indicated for management of symptoms. And specifically, we're talking about flushing, we're talking about sleep disturbance, vaginal symptoms, bladder symptoms, mood, and cognitive change. But I have some sympathy with this woman. If she is asking for hormone therapy to keep her quality of life, it does suggest that there is something going on in her background that she hasn't told us about. And there is concern which might be in one of those areas, I think, with specific focus. You have to remember, yes, that we are seeing benefit in young women in terms of slowing the rate of bone loss, slowing the rate of development of atherosclerosis, and increasingly we're concerned about slowing the rate of cognitive decline and the development of things like Alzheimer's and Parkinson's disease. If this is a working woman, I would have some sympathy that if she's taken the time to come and see you and ask about this, I wouldn't have much concern about allowing her to begin a therapeutic trial of estrogen-based therapy, whatever works for her, either oral or transdermal, whatever fits her lifestyle, with an annual review. And I think that's something that all the guidelines stipulate, that if you start anybody on hormone therapy for whatever reason, there should be at least an annual review of benefits and risks, so that she doesn't continue this with a blank check written to continue into the future. But I think, yes, certainly this woman is below the average age of menopause. There's questionable benefit in women who are menopausal after mid-40s, 45 and up, whether she would get long-term protection against morbidity. But I think there's accumulating evidence that she would get benefit. And my problem is that I do tend to have a bias towards the benefits for working women who increasingly rely on cognitive function, which we cannot let decline. So I would think we need to ask her specifically, which aspect of her quality of life does she want to maintain? If, for example, she just has urogenital symptoms, vaginal dryness or bladder symptoms, it may be better for her to use just vaginal estrogen without any systemic risk. But I think overall, I would be sympathetic to her having a therapeutic trial of whatever.
Sorry to interrupt you, but when to start?
I'm sorry, say again?
When to start?
When to start? Okay, that's a good thought. We haven't mentioned here that whether she is cycling or not cycling. So if
she's cycling, when to start? Or I should depend on a hormonal assay or something like that?
Yes, no, I see your point. If she is in fact still cycling, no, there's no benefit to be gained at this point for her. It's only when she is in fact postmenopausal. And I beg your pardon, I read that as somebody who is menopausal, but that's not stated in the synopsis. Okay.
Okay, let's move to the next question. If a patient who are diagnosed with an autoimmune disease and then had a unilateral oophorectomy due to a benign cause at the age of 43, then she had a menopause at the age of 47 with severe postmenopausal symptoms. Does HRT is indicated for her, taking in consideration that her autoimmune disease is still active and she's under treatment?
Well, generally speaking, autoimmune diseases are not contraindications to estrogen-based therapy. It depends what disease she actually has and what the manifestations are. But generally speaking, if she's got severe symptoms, no, hormone therapy is not contraindicated in her, and I think would certainly improve her quality of life. So
even if it is systemic lupus with vasculopathy, Tim, because that's probably
yes, exactly that. Thank you. Yeah, throw a curler in. It would depend if she did have significant vascular disease, then you would need to be much more cautious about any effects on vascular integrity. But if it's joint pain or if it's cutaneous, then no problem at all.
Great.
I would just also add a little bit. Well, I'm not an expert, but I just happen to have a patient similar to that
Yeah.
who's antiphospholipid antibody syndrome positive,
Okay.
or a woman who has a congenital thrombophilia, because we're getting more and more to diagnose those. I would
Right.
probably be careful about those patients too. Do you agree, Tim?
Yes and no. I think, yeah, it would depend to a large extent on the degree of disease. Somebody who has a thrombophilia will naturally be wary of any kind of treatment that might potentially increase her risk of thrombosis and thrombotic episodes. But again, there's no RCT evidence, but it is possible that transdermal estradiol in a low dose would get some benefit without any real effect on the risk of thrombosis. But again, that's something that would have to be performed in conjunction with the hematologist or rheumatologist or whoever's managing the condition.
Great. Question 3. Is a 50 years woman present with one episode of postmenopausal bleeding, lasts for 10 days. On the exam, she had an atrophic vagina and cervix, endometrial thickness 4 millimeter, history of breast cancer in her mother. How we can discuss an option of HRT for her? So she had a risk of breast cancer in her mother, family risk.
Right.
Otherwise, an episode of postmenopausal bleeding.
Right. No, there's a number of issues here.
Sorry, but this is an actual cases we are facing day by day.
Yes, thank you. Well, first of all, we'll say the episode of bleeding that lasted for 10 days. If there's no explanation for that, you may have to do an endometrial biopsy, particularly if she has concerns about cancer. Although Steve Goldstein, who is the current president of the International Menopause Society, published an opinion piece for the North American Menopause Society in the journal Menopause in December 2019, suggesting that a woman who is considered low risk, who has an episode of vaginal bleeding postmenopausally, and in whom ultrasound shows endometrial thickness of 4 millimeters or less, then no biopsy is required. I think this is one of those cases where you'd be inclined to do the biopsy simply because it sounds like she is concerned about potential cancer. And then you could move on to discussion of the options of hormone therapy. So let's say we've ruled out endometrial hyperplasia or endometrial cancer. The history of breast cancer in her mother is significant, perhaps, but it would depend to a large extent whether it was premenopausal breast cancer or postmenopausal, because premenopausal breast cancer does increase this woman's lifetime risk by possibly doubling it. Whereas if she had breast cancer postmenopausally, then the increased risk for this woman is minimal and would not necessarily affect your discussion of hormone therapy. I think you would have to say if she has a number of symptoms that make her life miserable, then estrogen-based therapy is going to be her best option because she will get the best improvement of each of those areas. But again, it would depend what aspect of menopausal change is of concern to her and what does she want to get rid of.
Great.
I'm not sure if I've been specific enough.
Yes. So I can understand that the family history of breast cancer, those with a premenopausal family history, is more harmful to them to have HRT than those with postmenopausal.
Absolutely. No,
this point should be clear in the mind of most of us. Okay, let's go to question 4. How different if we are dealing with women with
premature ovarian insufficiency.
Yes, premature ovarian failure or premature ovarian insufficiency.
It's interesting. Yes, Sue Davis, who was the past president of the International Menopause Society, did a webinar on this a couple of months ago and emphasized the difference. The key difference is the dose of estrogen, that women who have premature ovarian insufficiency by and large need higher doses of estrogen than women who are naturally menopausal for symptom control. So you are looking at avoiding the accelerated risk of loss of bone density and the accelerated risk of atherosclerosis. So doses of estradiol, 100 micrograms are standard transdermally, or oral estrogen, you're looking at 2 milligrams of micronized estradiol, or conjugated estrogen, 1.25 milligrams daily. So that's the key difference, that women who have POI, they should continue on higher doses, and they should continue until the average age of menopause. Then they make an independent decision about whether they want to continue.
Dr. Mohamed, comes to your question.
Well, actually, before we go to the next question, I want to ask Tim, do they still ovulate through this regimen? And my follow-up question, because I see quite a bit of those who are trying to get pregnant. So
Yes.
how related that to their sporadic ovulation and their ability to achieve pregnancy, particularly if they're in their early 30s and they want to get pregnant?
No, it's a fine point. I think if they use oral estrogen, and particularly high-dose oral estrogen, that does tend to inhibit the chance of ovulation and inhibits the potential for spontaneous pregnancy. Whereas transdermal estradiol does not. In order to inhibit ovulation with transdermal estradiol, you generally have to go up above 200 micrograms, which we're not using in these women. So yes, if a woman is actually having intermittent ovulation and wanting to conceive if possible, my preferred estrogen base would be transdermal in the standard dose. And certainly you would not use an oral contraceptive in this woman.
Back to you.
Yes, I have a question here. Is she going to keep this high dose forever, or going to reduce it near the actual age of menopause? And this is the same status in artificial menopause after oophorectomy? We should start with a high dose?
Very good point. No, the high dose applies to both surgical menopause and to early premature menopause. But as a woman passes 45, the dose could be tapered down, which is in parallel with what happens in the natural menopause.
That's great.
Yeah.
Okay, let's move to question 5. If a 50-year-old woman present with hot flashes and night sweats, her last menses was 8 months ago, her FSH is up to 45, she's anxious about starting HRT and asking for alternatives. So the question basically on the alternatives for those refusing starting HRT and suffering from hot flashes.
Very important question. There are 4 groups of agents, prescription agents, that we use for women who don't want to start hormone therapy. In other words, these are prescription non-hormonal options. And the first category are the SSRIs, SNRIs, the antidepressant group. And generally speaking, they will reduce the incidence of hot flashes by roughly 50%. Not all of them have been demonstrated to be effective. The ones that have been shown to be effective are venlafaxine, desvenlafaxine, paroxetine, citalopram, escitalopram. Those are the ones that have been shown in RCTs to be better than placebo. The second category are the anti-seizure medications, gabapentin and paragabalin. And these are agents that have to be started in a low dose and moved up. Generally speaking, for gabapentin, it's starting at 300 milligrams and moving up to 900 to 1200 milligrams daily. The knock with those is the sedative effect, which can be quite potent. So that women have to be cautioned if they use either of those agents, beware of sedation. The third category are the direct vascular effects of clonidine, which is an antihypertensive agent. It's an alpha adrenergic agonist. And it's because of that nature, it does tend to be associated with dizziness. And in addition, it's generally not very good at reducing hot flashes, certainly not the 50-odd% that has been reported with the SSRIs, SNRIs. So I don't use it much. And the newest non-hormonal option is an anticholinergic agent, oxybutynin, which is used to treat overactive bladder and has been shown in one RCT in 2018 to be quite effective at reducing hot flashes. They claimed in this almost 75% reduction in hot flashes, but it does also, it does produce some sedation, but dry mouth was the key side effect from that. But again, that's only one study. So we need more elaboration of that being an option. And you have to use quite high doses of it. So those are the four categories that I'm going to discuss with somebody who is anxious about using hormones. There are also a number of over-the-counter supplements, red clover extract and soy extract, but those are pretty hit or miss, and generally speaking have a minimal effect on hot flashes and night sweats. So I would tend to favor the non-hormonal prescription agents first.
Okay, great. Thank you very much. The question number 6, I think you touched this point about stroke.
Yeah.
And I think someone thought about using HRT as an adjuvant treatment for post-stroke patients.
Yeah,
based
you know,
on the your lecture today. So are there any evidence about using HRT to enhance recovery after stroke?
It's a very good point, and lots of people have proposed it, but nobody's been brave enough to have an RCT undertaken. And I think ethics committees probably would be wary about approving such an RCT, even though it seems like a nice idea. And I am inclined to think that transdermal estradiol probably would be a useful agent, but there is only theoretical evidence to support it. And again, if you did do this, you would be on your own if something bad happened.
Okay, question 7. In Egypt, you know, it's transdermal patches are not available.
Yes.
And some doctors using it of prescription, but it's not licensed in Egypt. The only available is the preparations that contain estradiol valerate and norgestrel, like cycloprogenova. So is it enough to be used as an HRT? Shall I use it continuously or interruptedly? And what about the bleeding episodes if I'm using either continuously?
Yes, and the problem is that there is very limited evidence to guide what the use of something like cycloprogenova would be like. It is possible to use it continuously, but I think in most cases, if we were to do that, we would probably recommend quarterly breaks. In other words, 3 months of use and then a week without for some withdrawal bleeding. I think, again, it's disappointing that you don't have more things available because, you know, there are much safer things to use than this preparation. I mean, a combination like that will be associated with mood change. There's evidence that it might be associated with an increased risk of breast cancer, not of endometrial cancer, fortunately, but if it's not designed to be used as menopausal therapy, we're all feeling our way with things like this. And I wish I could give you more guidance, but I would think the closest thing would be to use it cyclically.
Great. Question 8, are you going to start HRT immediately after surgical menopause?
Absolutely, yes. I think the only proviso would be if someone is immediately post-surgical, they have an increased risk of thrombosis. And that's why we recommend here using the patch, which doesn't appear to increase the risk of thrombosis further. But let's face it, following surgical menopause, women will tend to be symptomatic within days. And it is better if they can start right away. Now, in terms of the morbidities, obviously waiting until they've recovered from surgical menopause is fine. I'm thinking primarily of their surgical recovery and the fact that in addition to post-surgical discomfort, if they're also having sleep disturbance and hot flashes, life is pretty uncomfortable for them. And I wish I could send you some patches because that's what women here wake up. They do wake up with a patch on their hip. You know, they don't even know that they've started it.
So immediately.
Yeah.
Here a very interesting question, number 9. To which age we keep the ovaries in cases of hysterectomy for benign conditions? And does the morphological appearance of the ovary during surgery will affect my decision regardless of the age?
Well, I think no, that's a very good point. The second part of that is a bit easier than the first, because if an ovary looks peculiar, I think you're going to take it out anyway, or at least get a frozen section or something to guide you about whether it should come out or not. The other question is, you know, at what stage do we freely start to remove the ovaries? And I think there's not much question beyond the average age of menopause. You can justify removing the ovaries at the time of hysterectomy in order to reduce the theoretical risk of ovarian cancer. In the 40s, it's a bit more debatable. And in terms of the cognitive function, it seems like 43 to 45 is the age at which you start to say, okay, maybe these ovaries could come out if you're concerned about long-term ovarian cancer risk. But generally speaking, the age of natural menopause is an easier guide. And if someone is post-50, then they can come out. If they're less than 50, it's likely best to leave them unless they appear abnormal, in which case you use your surgical judgment.
I just want to add one thing here, because people should start changing their concept about removing the ovary to protect patients against ovarian cancer. Because now we have a lot of information and data. Actually, it is originated here in Vancouver that most ovarian cancer, particularly epithelial type, starts in the fallopian tube through what's called as stick lesions. So prophylactic salpingectomy is protective against ovarian cancer, and that you should do if you're making a decision about hysterectomy, irrespective of age. And I share with Tim his cautionary points about removing the ovary. If it is suspicious, probably if you don't have frozen section, I know that this is not as easy in Egypt as it is here. Probably a wash, peritoneal wash and cytology and irrigating the ovaries themselves. And then sending the cytology. And if you have any issues with that, you can always come. Well, the point here is, it's quite easy to come back to the ovary to remove them at any time. Just laparoscopic oophorectomy will take a few seconds. But if they are gone, they are gone forever. And if there is damage that you are incurring for the overall survival or the health of the women at the age of 40 or so, that the patient has to be stuck with hormone therapy for up to 10 years. But I want to, knowing how things are being done there, I want to caution people about taking it easy to remove healthy ovaries at the time of hysterectomy for other indications.
Very good point. Very good point.
I think question 10 comes from Dr. Mohamed. I think Tam had answered this question, or you would like to elaborate? Selective receptor modulators?
Oh, okay. Well, yes, no, there are two of these that we have in Canada. I'm not sure what the availability is in Egypt, but we're talking, I think, about selective estrogen receptor modulators. There are some for progesterone as well in development, but selective estrogen receptor modulators were developed hoping that the good effects of estrogen could be maintained in these things and the bad effects could be eliminated. And the first of these was raloxifene, which was introduced as a substitute for hormone therapy, but unfortunately was found to cause hot flashes. So it clearly wasn't an option for managing menopausal symptoms. On the other hand, it did, like estrogen, increase heart health, and it did maintain bone density. So it is used as a bone trophic agent in Canada and elsewhere, but it's just not very popular because of the incidence of hot flashes in postmenopausal women. The newer one is a SERM, selective estrogen receptor modulator, called bazodoxifene, which has been combined with conjugated estrogen in a single tablet here called a TSEC, a tissue selective estrogen complex. In other words, it's two kinds of estrogen, traditional conjugated estrogen and this selective estrogen receptor modulator, which is neutral in breast tissue. It's neutral in the endometrium. So it doesn't cause bleeding, doesn't increase the risk of endometrial hyperplasia. And it appears at this stage to reduce or has a neutral effect on breast density. We're hoping in the future it will be shown to reduce the risk of breast cancer, but that's quite a long way off. And there is no prospective study being conducted to show that that's the case. But I think if that combination does prove to show that the risk of breast cancer can be reduced while menopausal symptoms at the same time relieved, this will be a very popular agent. Unfortunately, at the moment, that particular combination is off the market because of a packaging issue. It wasn't found to be dangerous to use, but it couldn't be packaged in the right kind of plastic packaging. And the company, Pfizer, which makes it, has been trying desperately to find a way to package it and send it out again because it's very popular with a good number of women.
Great. Are there a time for 2 or 3 more questions?
Sure.
We took a lot of your time today, but I think the questions are very interesting. You know, we have a high prevalence of hepatitis B and C in Egypt. Yes. So for those who are cured from hepatitis, receive the treatment for hepatitis C, and they have no active disease, is it safe to start HRT for them?
It is. I would again have the qualification because I actually have a number of patients from the Middle East who are in this very situation, that they have a history of Hep B or Hep C, but now considered cured. I think because oral estrogen in particular does have cholestatic effects in the liver, you do have to maintain monitoring of liver function in women who are on this. And you will likely have much less of an effect if you can deliver it transdermally, as we do with these women. But if you don't, if you are forced to use oral estrogen, you would have to be very careful in monitoring them to make sure that there's no adverse effect on what may already be compromised liver function.
So transdermal transdermal is safer here for these type of patients.
Transdermal is certainly safer for this.
Great. Mohamed.
How much elevation of transaminases can you tolerate while you're monitoring them?
Wow.
Wow. I would think, I'm extrapolating here, and the ones that I have seen all had normal liver function, actually. They had normal transaminases. I'm extrapolating from the women with Turner syndrome, who often have elevated transaminases, and the transdermal estrogens don't appear to make any difference in those women. But I think, no, if something was increasing, or if they had a clearly significantly elevated level of transaminases in the hundreds, you would
It's
probably
10 o'clock.
Great. What about the use of HRT in the women with strong family history of breast cancer? I think you covered this point, but I think the question here, is it just a family history, or we can say there is something called strong family history and relatively,
I think that's absolutely right. You know, there are different kinds of family history of breast cancer. If someone's grandmother developed breast cancer when they were 80, that clearly doesn't count. But if you have a first-degree relative who developed premenopausal breast cancer, most of those women you would be very, very reluctant to give hormone therapy to. And I would talk primarily about the non-hormonal options.
Great. 2 questions to go. Can you comment on the use of the bioidentical hormones versus conventional MHT?
Yes. There was actually a report released by the the Academy of Medicine in the US in the past year that included a number of recommendations about the use of bioidentical, that is, compounded hormones prepared by individual pharmacies, saying essentially don't use them. And I think the justification I use for women who come in demanding that they have compounded estrogen therapy, there are popular ones here called Biest and Triest, which are combinations of different kinds of estrogen. Triest obviously has estrone, estradiol, and estriol. Biest is mostly estriol and some estradiol. But there was a study by the Mayo Clinic published in 2014 that randomized women to treatment with these Biest compounds and a patch, and showed that women who were using the bioidentical hormones weren't getting anything like the levels of serum estradiol or estriol that they thought they were. So essentially they were paying a lot more, having much lower serum levels, and having uncertain reliability from one batch to another. The thing is about these compounded preparations, there's essentially no safety data whatsoever, and efficacy might be largely a placebo effect. So this statement from National Institutes of Health in the US said, don't use them.
Okay, the last question we have today, and I would like to add one final question. Should all women receive HRT once they reach menopause? I think you answered this part of the question in the first case scenario, or just those with symptoms. It's clear with symptoms, and for how long?
Yes.
The third part of the story is for how long?
That's right. Well, I think, yes, we have talked about this before. No, not everybody needs to take it. It's really for symptomatic treatment, even though there are these implied benefits with long-term use. What I do is review everybody who does this annually, because the evidence keeps changing as well. And each year there's a new study or two to talk about that will color what we say about continuing with hormone treatment. So there's no upper age limit. We do know that beyond 5 years, there may be an increase in the risk of breast cancer, but that will depend on many other factors as well. That may color the judgment of a lot of people if they feel there's even the tiniest increase in risk of breast cancer. But I will say, in response to people who are skeptical about long-term use, there was a study published late last year from Cache County in the US, looking at cognitive function in women in their 80s who had continued to use hormone therapy. And in comparison with women who had stopped, the women who were on hormone therapy were cognitively way ahead and much better, much more active cognitively than those without. So I think increasingly we're going to be looking at the cognitive benefits, the neurological benefits as a major reason for favoring use of hormone therapy.
If Professor Bedaiwy allows me to put a final question, you said too much about the annual reviewing. What this annual reviewing include?
Yep.
Should be clear in the mind of our graduates here and our students.
Understood. It means an assessment of cardiovascular risk, which changes from time to time. Mostly now we're just using abdominal circumference to say whether someone is at increased risk. There are a number of online cardiovascular risk options. The Framingham assessment is a good one, and you can Google that, and it's freely available to say what a woman's cardiovascular risk is. And we also need to know what her bone health risk is. Is she somebody who has dairy in her diet? What's her calcium intake? What's her vitamin D intake? These are the primary concerns that we have, but we also want to know about whether they've developed any new medical issues, whether they may have had a thrombosis, or they may have had a suggestion of cardiovascular disease, whether or not they've had any surgical interventions, whether they're on any new therapy that might interfere with what they're taking. So it's a general medical review, but the focus will be on cardiovascular risk and bone health before deciding whether they should continue or not. And that's—
What about breast?
What's that?
What about breast?
Again, that's assuming that you have regular assessment of breast health. In Canada, we're lucky we have a screening mammography program that does this out of sight. But I think, yes, if somebody is not having regular mammography, then at least some degree of assessment of breast health, including family history, alcohol use, exercise, things that will affect her individual risk of breast cancer, should all be taken into account.
But there's no need to increase the follow-up mammography rate rather than the normal follow-up for any suitable age woman.
No, absolutely not.
That's great. We took a lot of your time, and we leave Mohamed to conclude, and thank you very much.
You're very welcome. Thank you, Omar.
Yeah, Tim and Omar, that was great. I think the question and answer part was a fantastic addition, and it was actually generated based on the feedback that we got from previous conversation, that people get more from clinical scenarios. But today you got it all, Tim, all the science, all the updated information, and we have given you the most questions you've ever got probably in any single lecture, because of the hunger for menopause in this area and your unique knowledge in that regard. So on the behalf of Assiut University and the behalf of the audience and myself, obviously, I really thank you very much for your generosity, and we look forward for some more contributions in the future.
Thank you, Mohamed. No, it was a great pleasure. Thank you.
Thank you.